Adams, Marvin Devine, Hoover, Axel, and you know how we do. Yeah, I got the juice. Whip game cool, make them look like cool. Always play cool, that's the biggest rule. Fuck that, what they doing, keep on doing. I've been making loot since like 22. Ask me how I made it right here in the booth. I'm always pursued cause of what I pursue. That's greatness, yeah, I gotta make it, I got things to lose. Boy, wanna get in my crew, but you can't get in my crew. Me, Axel, and Hugo, way too fireable. When this joint drop, that is called the truth. And when you hear the drop, better raise the roof. Better raise the roof. You already know what happens with me. We link up. Let's go. Yeah, I got the juice.
All these brothers, my guys, know that they fly, know that they ride or die. I keep waves by my side, CJ Ike, now I gotta roll with ice. Cold, these brothers, my guys, know that they fly, know that they ride or die. I keep waves by my side, CJ Ike, now I gotta roll with ice. Ride or die, 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 ride or die. Cold, these brothers, my guys, know that they fly, know that they ride or die. I keep waves by my side, CJ Ike, now I gotta ride or die.
Hello, 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 everybody. Welcome, welcome, welcome. Tonight, the great Dr. Ken Sutha is with us. Let me tell you a little bit about our guest. Dr. Sutha is a MD, a PhD, a board-certified pediatric nephrologist, instructor, and postdoctoral research fellow at Lucile Packard Children's Hospital, Stanford, and Stanford University School of Medicine in Palo Alto, California. He completed his undergraduate degree at Yale and his MD and PhD training in biomedical engineering at Emory University and Georgia Institute of Technology before pursuing his residency in pediatrics at the University of Washington in Seattle Children's Hospital. He then moved to Stanford for his pediatric nephrology fellowship, where he has remained as a faculty member and now devotes his time to a combination of patient care, advocacy, and research. In addition to his clinical duties, which at LPCH, which has performed the largest volume of pediatric kidney transplants in the United States over the last 5 years. He serves on their ethics committee as well as the boards of the American Living Organ Donor Fund, the Stanford Medical Abilities Coalition, and volunteers as a Donate Life ambassador for Donor Network West. Additionally, he's been recognized for his advocacy as the 2019 American Kidney Fund Hero of Hope and for his research as an American Society of Nephrology as a Jared J. Grantham Research Scholar. He's also a two-time kidney transplant patient. Please give a warm welcome to our guest, Dr. Ken Sutha. Doc, how are you?
Doing great. How are you? Thank you so much for that great introduction.
Did I get everything right? Did I misstate anything?
Yes, no, that was all 100% correct. That was me.
Great. Doc, tell us a little bit about where you grew up and your childhood.
Yeah, so I'm originally from Jacksonville, Florida. I was born just outside of DC in Silver Spring, Maryland, close to where the NIH is. But then my parents moved down to Florida when I was about like 2 or 3 years old. I grew up there, stayed there until I graduated from high school, and then went off to college. Both my parents are from Thailand. They're immigrants from Thailand. They actually went to high school together, but didn't meet until they came here to the United States. But yeah, I had a great time growing up. I'm an only child, but I'm close to several other family, like extended family, cousins, etc.
Wonderful. I understand that you live close to Palo Alto, California, right at the moment?
That's correct. I live just on the border of Palo Alto and another town called Menlo Park, which is actually the town where Facebook's headquarters is. And so I'm literally just down the road from Facebook.
Talk to us a little bit. What is your current profession? What do you currently practice? What's the nature of your practice?
Yeah, so as you mentioned in the introduction, I am a pediatric nephrologist. What that means, of course, is that I'm a pediatrician. So I take care of kids of all different ages, all the way from newborns to sometimes even like young adults, 20-something-year-olds. And in addition to that, as a nephrologist, I take care of kids with all kinds of kidney diseases. That can be anything from abnormal blood or protein in the urine, high blood pressure, to other things like more serious conditions like abnormal development of the kidney, leading to kidney failure, requiring dialysis, and then eventually transplant.
Okay. Explain to us, why do you practice with pediatric kidney patients? It's my understanding that there's not too many of you board certified guys in that particular area of the profession.
That's correct. So luckily, there aren't a super large number of kids that have kidney disease, but there's still a small number of pediatric nephrologists for the number of patients that there are with pediatric kidney disease. And so we tend to work in more centralized locations where patients often have to travel long distances to come and see us. I really enjoy working in pediatric nephrology because, number one, I love pediatrics. I love working with children. I think that there's so much hope and future ahead of them, and we have the ability to have such a huge impact on their lives as pediatricians. And I particularly love nephrology because we have such great relationships with our patients. Again, as I mentioned, since there aren't that many of us, we take care of kids with all kinds of kidney disease. We take care of them all the way from when they're first diagnosed to when they have to go on dialysis, and then we continue to follow them after transplant. And so we have these long multi-year relationships with them, and so we can really see them grow and develop and change. Also, we can take care of things inside the hospital and outside the hospital. So there's a good mixture of very serious, complex, hard things, but then also more routine things that to kind of mix things up.
Let's talk about your experience as a kidney patient yourself. What year and how old were you when you first discovered that you had issues with your kidneys?
Sure. So I was first diagnosed with kidney disease when I was about 10 years old. That I think was back in 1994. On a routine test at my pediatrician's office, they discovered that I had abnormal amounts of protein in my urine, which is not normal. They did some additional tests and found that it continued to be there. And so they thought that I had something called nephrotic syndrome, which is one of the more common types of kidney problems that can happen in kids. It's not a super common thing in the general population, but in terms of things that pediatric nephrologists see, it happens more often. Most kids that have nephrotic syndrome are able to be treated with steroids, and the disease may come and go in terms of its severity, but eventually they outgrow it. And the hope was that would be the case for me. So I was treated with a course of steroids, but didn't respond to them in the way that we would normally expect. And so because of that, they did a biopsy and took a small sample of my kidney and found that I had something called FSGS, focal segmental glomerulosclerosis, which basically means that there's scarring of the kidney. That can actually be caused by a variety of different things. But basically, they knew that my kidneys were spilling protein. That was a sign of damage that had already happened to the kidney, but that the protein itself, because I was losing the protein, it was also causing additional damage to my kidneys. And so they weren't able to do any kinds of treatments to really stop the underlying cause of my kidney disease, but they were able to put me on some medications that could slow the progression, reduce the amount of protein, and make it so that my kidneys lasted longer than they probably would have if I hadn't been diagnosed. And because of that, I was able to graduate high school, went for about another decade or so, a little bit over a decade, while my kidney function slowly went down.
During this period of time that you were being treated for the protein in your urine, and I believe you wrote me a note, ACE-I was the kind of treatment that you received. Did I pronounce that correctly? Were there any limitations on your activities?
Yeah, so ACE inhibitors are normally are routinely used as a blood pressure medication. They help to keep people whose blood pressure is high lower. And so one of the main side effects is that it can cause your blood pressure to go low if you're taking it for other reasons besides blood pressure, high blood pressure. So my blood pressure wasn't high at the time, but the medication, in addition to lowering blood pressure, also has an effect in lowering the amount of protein in the urine. And it was quite effective at doing that for me, but wasn't able to remove the protein completely. And so I had to be careful about making sure that I was staying well hydrated, watching my blood pressure, making sure that my blood pressure didn't get too low, that I wasn't dizzy, having other issues like that. If that happens, there can also be issues where it can actually harm the kidney, because if your blood pressure is too low, not enough blood is getting to your kidneys, and that's not good for them either. And so it's a balance that needs to be struck.
Okay. Tell us, where did you go to college? What year did you graduate? And what was going on with your kidneys about that time?
Sure. So I graduated from high school in 2000, class of 2000, right after the millennium. And I went to college at Yale, up in Connecticut. I was there for 4 years. During that time, I was just on very few medications, just that ACE inhibitor that I mentioned. And, being in college, trying to understand why I was taking the medication, why I needed to take the medication, explaining to other people why I was taking it, what my kidney disease was difficult for me at the time, because I had some understanding, but oftentimes, as is the case for many people, you don't really feel the effects of kidney disease until you're at the very, very later stages of it. And so I felt like I was doing pretty well, pretty normal, had normal amounts of energy and activity levels. And so sometimes it was difficult for me to remember what was the reason that I needed to take this medicine. And so that sometimes led to me not taking my medicine as consistently on schedule as I was supposed to, sometimes missing doses if I was out doing things, hanging out with friends or something like that, or I woke up late or something else. But as college went on, I followed up with my nephrologist and found that as it had been over the past decade, my kidney function was continuing to slowly deteriorate and get worse. And some of the side effects of kidney disease were slowly starting to creep in. Some of the issues with abnormalities in some of the levels in my salts in my blood, and other things like that that are seen on blood tests. And again, still not necessarily things that I even felt or was able to tell physically that were going on with me, but that were different about my blood tests. And so I had to realize that I needed to be more serious about my health, my activity, what I was eating, to try to prolong the health of my kidney as long as possible.
Okay. What year did you graduate from college?
Right. So I graduated in 2004. By that time, it was becoming increasingly clear that my kidney function was getting worse, and that dialysis or transplant would be in my near future. And so at that time, I was also trying to decide where I would be going for medical school. And so trying to weigh, knowing that in my very near future, I would have this serious medical issues coming up, but also deciding what would be best for me in terms of my career. I was very fortunate that I was admitted to an outstanding program at Emory that has outstanding nephrologists and an amazing transplant program, and is closer to my family in Florida. And so I ended up in Atlanta for medical school.
Okay, it's my understanding that you received a preemptive kidney transplant at some point in time. Can you tell us where and when, and please describe the circumstances?
Yeah. So as you mentioned, I got a preemptive kidney transplant. So that means before I needed to start dialysis for my dad. So my dad was 60 years old at the time, but otherwise in really great health. And so he was able to go and get tested, to go through the full testing process. I was at Emory University in Atlanta. And so he drove up from Florida, got all the testing done, and was a good match to be able to donate his kidney to me. So about 2 years into medical school for me, I was towards the end of taking all of my classes, about to take our big licensing exam. But then at that time, it was clear that dialysis was on the horizon. And so I ended up having to move up the transplant and get that done as soon as possible. And then thankfully, things went really well with the transplant, and I recovered pretty quickly after it. Was able to, within like a month or two after the transplant, start studying for my big exam. Took my big national license exam on time with the rest of my class, and then was able to carry on with the rest of my my training.
Okay, it's also my understanding your father is also a doctor, correct?
He is a PhD doctor, so he's an engineer, and does has a PhD and is trained as an electrical engineer and did some aerospace engineering stuff. My mom, however, is a physician. She's a radiation oncologist, so takes care of patients with cancer.
Wow, really smart. It runs in your family, Ken. Wow.
My parents are much smarter than I am.
Well, the whole group, you're smarter than I am. So my producer's always fascinated by this number. I understand that as we're talking today, you're walking around with approximately 4 kidneys in your system?
That's correct. So a little a common misconception about people that people have about transplants is that they take the old kidneys out. But actually, your kidneys, they sit kind of towards your back and are at a little bit more difficult place to get to. So transplanted kidneys actually go in the front of your abdomen, kind of like near your pelvis. And when I got my second transplant, they decided they would just leave my original transplant place and just put the second transplant on the other side. So I have my 2 kidneys that I was born with, my 1 kidney from my dad, and then a second transplant that I got now about 3 years ago.
Something else that I found remarkable in your bio is some of the activities that you were engaged in after your transplant. Can you tell us a little bit about that?
Yeah. So I never considered myself to be athletic or a sporty kind of type person. I did crew in high school, but I was what's called the coxswain, which is the person who sits in the back of the boat and steers and yells at everybody. But knowing that the medications, particularly steroids, tacrolimus, that I needed to take to keep my transplant healthy, they put you at risk for things like diabetes, high blood pressure, and other things that can, again, be damaging to the kidney. And so I knew that being healthy through diet and exercise were important. I heard about the transplant games from a friend. Actually, her name is Melissa Carter. She is a radio DJ in Atlanta, kidney recipient. She had gone to the transplant games and talked about them and raved about them. And so I set my sights on being able to go to the transplant games and decided that I would start swimming. I knew how to swim growing up in Florida, but never had done it competitively. So I joined basically an adult swim team, a master's team, where they were able to teach me the different strokes and the proper technique and way to do them. And so about 2 years after my transplant, I went and competed at the transplant games and actually won some medals. I've also been able to take part in other kinds of activities. When I was living in Seattle, the University of Washington has a great program called Team Transplant, which is a program for patients with transplants and some waiting for transplants as well, to go through a training program for training for a marathon or a half marathon. And it was a great way to build community, get out and get exercise, and was able to do a half marathon by participating in that program as well. Wow.
Okay, so you're pursuing your residency in pediatrics at the University of Washington and Seattle's Children. I also have a note here that you were a volunteer at Kidney Camp for Children, and this was particularly significant. Can you talk to us a little bit about that, please?
Yes, definitely. So right around the time that I got my transplant, I had heard from friends who had volunteered at other kinds of medical camps for kids with different kinds of medical diseases. So there is a camp outside of Atlanta that works very closely with Children's Healthcare of Atlanta called Camp Twin Lakes. Over the summer, basically every week, they host a camp for a different kind of disease: kids with cancer, kids with different kinds of kidney disease, kids with heart disease, etc. And so I set my sights on being able to go and do that. I recovered enough after my transplant that about 3 months after my transplant, I was able to go and be a camp counselor at this camp, specifically at their week that they have kids with kidney disease on dialysis and all kinds of transplants. One of the amazing things about this camp is that they were able to do dialysis on site, both peritoneal dialysis and hemodialysis. And that since there were nurses there and doctors, that they were able to look after the kids, help manage any issues that they were having, make sure that they were getting all their medications, so that their parents wouldn't have to worry about them being off at camp, but that the kids would be able to do all the kind of camp fun things that you can imagine. For me, that was a really important experience in being able to see the amazing power of transplant, and that the difference that it made in these kids' lives, allowing them to just be kids. And I think that experience, really drove me first to want to be a pediatrician, and then ultimately to be a pediatric nephrologist working with kids with transplants.
Okay. Talk to us a little bit. I have a number of friends with FSGS. Talk to us a little bit about the complications with FSGS and kidney transplant. And I know you do some research. Are you following research in the FSGS area?
Yes. So FSGS is a misunderstood and poorly understood disease. So the name, again, FSGS, is basically a description of what's seen when doctors, pathologists, look at the sample of the kidney under a microscope. That basically means that there's scarring. And in that way, it's a description of what it is, but it doesn't say anything about what the actual underlying cause of it is. So over the last several years, we've actually come to a much better understanding that FSGS is actually not one thing, but a collection of several different underlying diseases that have the same appearance. And so that can be some sort of autoimmune process. It can be scarring that's because the kidneys didn't develop correctly. And it can be from a variety of different things. And research over the past several years related to genetic testing has been really important in being able to figure that out. By doing genetic testing and research, they found that all these people that we were previously lumping together as one disease, FSGS, are actually all these multiple different things. And in understanding that they're actually separate entities, that helps us to direct the kinds of medications that we're using to treat the underlying cause. Because what might work for one form of FSGS may not work for another form, and in fact may have detrimental side effects and lead to complications. One of the scariest things about FSGS is that certain forms of FSGS can actually recur or come back and attack a transplanted kidney after transplant. This can happen almost immediately after a transplant as well. The thought is that the body is making some sort of factor that is attacking the kidney. And it's still a source of debate within the field of nephrology, what exactly that factor is. And again, if you're able to sort out which patients are going to be at risk for having that recurrence happen, that helps to inform decisions about the treatments and how vigilant or careful we need to be when doing a transplant for those patients.
Okay. Did there come a time when your first kidney transplant failed? When was that? What part of your education or practice did this occur in? And please talk to us about the complications and infections that occurred during this time period.
Right. So ultimately, my kidney failed about a decade after my first transplant, but there was actually a little bit of a bumpy road to get there over those 10 years beforehand. So many times people think, we get a transplant, everything is sunshine and flowers, and everything is magically cured. But that is unfortunately not the case. Transplant is a treatment and not a cure, in that it comes with its own set of complications and side effects. It requires lifelong medications and sticking very carefully to them, being careful about infections, like we're seeing now during the COVID-19 pandemic, and even in the best case scenarios, over longer periods of time, there can be further damage that happens to the kidney, where the transplanted kidney function declines over time. In my case, I had a couple of issues. First of all, about less than a year after my transplant, I started having increase in my creatinine. They did a biopsy and found that it was related to side effects and toxicity from the Prograf. Prograf, of course, is a very important medication that we take as an immunosuppressant, as an anti-rejection medication to prevent our immune system from attacking the kidney. But it also has a side effect of being toxic and tough on the kidney itself as well. And this is a very difficult balance to strike. Sometimes in other transplant patients, liver and heart transplant patients, for example, they can actually develop kidney failure and kidney disease because of the Prograf or the tacrolimus that they take for their transplants. And that's also the case for patients with kidney disease. As I mentioned, they found that I was having issues with from the Prograf, and so they switched me to another medication called Rapamune or sirolimus, and that seemed like that settled things out for a while. I then started to have issues with unexplained fevers and GI side effects. It was eventually they found that it was related to something called EBV, Epstein-Barr virus. This virus, EBV, is a common virus that's seen in like, I think 70 or 80% of the normal population. In normal people, it leads to mono, and then they get over it and it goes away. But unfortunately, in transplant patients, it can come back when the immune system is suppressed, and it can lead to problems. If it gets really out of control, it can sometimes even lead to certain forms of cancer. And so that's why doctors are very concerned about it and check it if there's an issue. Again, since I had that and I had problems with that, that was a sign that my immune suppression was too high. And so step by step, they eventually took away some of my immune suppressive medications. They reduced the target level for my sirolimus, for my Rapamune, and eventually they also stopped my CellCept altogether. The hope being that by reducing my immunosuppression, my body would be able to fight off this infection. Unfortunately, even with all those measures, the virus still hung around in my body. It was at a low enough level that was controlled and not causing problems, but it never completely went away. And so they decided they would keep me on a low level. However, as we know, when you lower immunosuppression, you also run the risk of rejection again as well. And so after being on that very low level of immunosuppression for several years, they found that I started to develop antibodies to my kidney and was in rejection. And so they switched me back to tacrolimus and restarted the CellCept. So put me back on the full immunosuppression. With that now increased immunosuppression again, that put me at risk for more infections again, a second time, this time with a different virus called CMV, cytomegalovirus, which is another common virus. Again, in the normal population, doesn't cause many problems, but in transplant patients can lead to a lot of issues. And so for many years, it was this ping pong back and forth between different kinds of viruses and adjusting my immunosuppression that eventually led to damage to my kidney from rejection.
Okay. Did there come a time when you had to go on dialysis? And if so, when did that occur, and what modality of dialysis did you choose?
Yes. So I was going through all of these treatments for rejection, like towards the end of my time in medical school, and then I moved to Seattle to do my residency in pediatrics. At the very end of my training in pediatrics, at the end of 3 years, this was back in 2016. That was the time that my kidneys finally had reached the end, and they had decided that the treatments weren't working anymore, and that I would need to go back on dialysis. I was fortunate that I was able to do a form of dialysis called peritoneal dialysis, different from hemodialysis. Peritoneal dialysis, basically, you put fluid into your belly, into your abdomen, and you use your body's peritoneal membrane, which is basically like the inside lining of your gut, to be able to do the dialysis. One of the great things about it is that you can do it at home, and that you have control over your schedule. You don't have to go to a dialysis center for multiple hours several times a week like you would with most forms of in-center hemodialysis. And because of that, that allowed me to continue working full-time as a doctor, both at the end of my training in pediatrics in residency, and then when I moved down here to California to be a pediatric nephrology fellow. So I would go to, for example, my day I would unhook myself from dialysis in the morning, go to work early, something like 7:30, stay there all day, and then go home, hook myself back up to dialysis, and then be on dialysis overnight.
Wow. I don't know how you did that with as busy a guy as you are. That's amazing. I understand that there came a period in time where you actually had a second kidney transplant. I think July 24th, 2018. Do I have the date correct?
Yes, that's correct.
Can you tell us a little bit about that?
Yeah. So after about 2 years on dialysis, on peritoneal dialysis, I was fortunate that I received a deceased donor transplant. Because I had been in Seattle at the time that my kidneys eventually failed and I started dialysis, I still had my listing up in Seattle. I also was evaluated for transplant down here at Stanford because, of course, being able to be transplanted right here at the hospital where I work would be super convenient. But unfortunately, the waiting times for transplants are very long here in California. And so even though I was trying to get living donors worked up to have a transplant here in California, I kept my deceased donor transplant waiting list time up in Seattle. Of course, I'm extremely privileged that I have the resources to be able to do that and to be able to travel to a transplant center in another state at the drop of a hat like that. And many people, of course, do not have that option. There were actually several times where there were false alarms where I got called in for transplant, and being in a different state, had to get on a plane, pack up all my dialysis supplies, my PD machine, take it with me up to Seattle. Once over Christmas Eve, or no, New Year's Eve, actually, I was actually admitted to the hospital, taken down to the operating room before they discovered that there was actually something wrong with the donor kidney, and things were called off. But again, I was very thankful that in July that year that things finally worked out for me, and I got a transplant, and I had a very smooth recovery.
Excellent, excellent. It's my understanding during this period of time, you're still seeing patients, you're still working in the lab. Can you tell us, how are you able to do that?
It was very difficult, and in retrospect, it was probably more than I was probably pushing myself more than I probably should have. I think that it put a lot of stress on my body. I think oftentimes we try to there's, particularly in medicine, there's a culture of like that doctors are like superhuman, and that we do like these 24-hour calls in the hospital, and we do all these things for the benefit of our patients. But I think there needs to be a shift, and there is a shift that's happening, that we need to do a better job of taking care of ourselves. I think I'm used to being like a very high achieving person, and I was probably pushing myself more than I really needed to. Things worked out for me because I had a really great support system. My colleagues that work with me, my roommate at the time, my family, that enabled me to continue to be able to do all those things. But I think I think my message to other people is that you don't have to do that. When I talk to other students, other people with kidney disease, other kinds of disabilities, I try to emphasize that we need to give ourselves some more grace, and allow ourselves to be human.
Talk to us a little bit about the clinical research that you were doing for kidney patients. Can you please describe for us the research that you've been doing, how long you've been doing, and what is your long-range goal for your kidney research?
Right. So I've been doing a couple of different things. So I saw a comment in the chat about peritonitis. So I did not, I was fortunate I didn't have peritonitis during my time on peritoneal dialysis, but it is definitely a big problem for patients that do PD, especially since they're doing the connections themselves, they're at home. There are many opportunities where there could be contamination. One of the problems with peritonitis is that it can cause scarring to the peritoneum that can then make it more difficult to do peritoneal dialysis, and eventually force people to move from peritoneal dialysis to in-center hemodialysis. So I was fortunate that Stanford has an engineering school, and I was able to work with a group of students doing their senior design project in biomedical engineering. Again, my degrees are in biomedical engineering as well, so I was really excited for this opportunity. And so for their senior design project, they built a device that they are hoping to be able to use to monitor patients' peritoneal dialysis fluid while they're on peritoneal dialysis to check for signs of infection and peritonitis, so that it could potentially be caught earlier before patients actually get too sick from it and before it causes more irreversible damage to the peritoneum. They have actually been very successful with the work that they've done. They submitted to the Kidney X project, which was a project developed by the American Society of Nephrology and the Department of Health and Human Services to try to fund new ideas in kidney research, basically like the X Prize for dialysis and for kidney disease. This has been really, really exciting because it's helped to promote bringing new ideas and new people into the field of kidney and dialysis research that might otherwise not have come in here. And that was exactly the case with my students. And so again, they submitted for this prize, and they actually won one of the first round prizes for the Kidney X. They're continuing to work on their project now, a couple of years out, hoping to submit it for some publication soon too. So continue to look out for that, more information about that. It's a device called Optic Line. So keep that name in your memory. I also do research in a lab, trying to grow kidney tissue in a dish. One of the ways that we could potentially develop new treatments and get a better understanding for kidney disease is by being able to manipulate kidney tissue in a lab so that we can test more kinds of drugs and get a better understanding of what the interactions are between those cells of the kidney. And so I'm trying to develop new ways to do that.
Okay. So in other words, with the research you're doing in the lab, that has to do with possibly regenerating kidney tissue and saving your old kidneys as opposed to transplant dialysis type of modality. Would that be a fair statement, Doctor?
In the long term, that is the ultimate goal, I think. It's still going to be a little while until that's a reality, but I think we are making really important steps in that direction. In particular, in the past 5 years or so, the field has really exploded and has moved forward quite a bit. And so it's a really, really exciting time to be involved in kidney research right now.
Okay. I want to talk to you about one of the recurring themes that I see in your work, the things that you've written and in your videos. And by the way, just for our audience, there are a number of links that I have posted in the comments that deal with our guest tonight. So if you want more information on the doc, all you have to do is check out the links in the comments. One of the things that I noticed is you talk an awful lot about the use of PD in pediatric kidney patients. Can you tell us a little bit about how that works? Because I imagine there are people who would be concerned about age limits, pros and cons of peritoneal dialysis with children, advantages, disadvantages. Give us your thoughts, please.
So there are definitely pros and cons to all of the different forms of dialysis. And it's definitely a very personal decision between each individual patient and their doctor as to which kind is going to be the best for them. In general, my opinion is that home kinds of dialysis are better because you get a little bit of dialysis more frequently, as opposed to having to squeeze all of your kidney function into just a few short hours a couple of times a week, as one does when they go to in-center hemodialysis. There are, of course, advantages to in-center hemodialysis as well, in terms of not having to have all that medicalization and all the supplies and machines that you need at home, and having nurses that are able to help you with all that and to help manage your medications in that way. But for example, for me, I knew that I wanted to do a form of home dialysis because of the flexibility that I needed to continue working and to do the things that I wanted to do in life, being a relatively young person with kidney disease. In kids, we like peritoneal dialysis oftentimes, again, because it's a little bit more gentle on patients, because the blood volume of a kid is compared to the blood volume that has to be inside the dialysis machine. If you're trying to take out large volumes of blood from a kid, it can lead to a lot more trouble, more difficulty with blood pressure issues and other issues like that. And so for those reasons, we do like peritoneal dialysis. Oftentimes as well, again, since as you mentioned before, there aren't very many, as many pediatric nephrologists, and we tend to be kind of localized in only a few locations. But our patients, they live all over the place. And so somebody who lives, for example, in the northern part of California, may not have a pediatric nephrologist or a hemodialysis center that's able to do dialysis on a younger child. And so if they were on hemodialysis, they would either have to drive several hours to our pediatric dialysis center, or they would have to relocate their family to live close by to the hospital. And for that reason, being able to do peritoneal dialysis, they can do that at home. They only have to come into the hospital to see the doctor once a month for their doctor's visits, as opposed to 3 times a week, like they might have if they were on hemodialysis. We're trying to do more home hemodialysis for kids as well, but so far it's something a little bit more limited to older teens and bigger kids. But particularly for younger kids, infants even, peritoneal dialysis is often a good choice.
Okay, let's talk a little bit about your kidney advocacy for kidney patients like you and myself. What organizations have you worked with, and what is the nature of your activities with these groups?
I've worked with many different organizations, basically all the kidney disease organizations under the sun, from the National Kidney Foundation, the American Kidney Fund, the American Association of Kidney Patients, the Georgia Transplant Foundation, different OPOs in all the different states that I've lived. I really love giving back. Even before my transplant, I got involved with volunteering because, number one, since growing up, I never really knew anybody else with kidney disease or who needed a transplant. Being able to volunteer, it gave me an outlet to be able to connect with other people who were going through similar circumstances as me, but also to be able to give back and educate other people. I started out, as I mentioned before, being a volunteer at summer camps. One of them, the first one that I did, was run by the National Kidney Foundation at the time. And then I also volunteered at health fairs, doing screening for kidney disease. Eventually, as I got more comfortable with my own kidney disease, I began speaking about it. And so doing speaking engagements with different groups, raising awareness about transplant, signing up organ donors, talking to people about kidney disease. That's how I got involved with the American Kidney Fund. I came across one of their opportunities to be able to go and travel to Washington, D.C. to speak with our congressmen and women about kidney disease, to tell them and educate them about the importance of funding for kidney disease research and different bills that were under consideration to support kidney and transplant patients. And that was a really fantastic and amazing opportunity to learn how to use my voice as both a patient and a physician to really be able to see change in the way that kidney disease is treated and thought about on a national level.
I've also seen some of the things that you've written, and I've seen some of your webinars on YouTube. Can you tell us a little bit about those things, please?
Sure. So I've done speaking again, similar to this, through several outlets on urban health media, which I really love collaborating with. I've done some things related to recently, particularly raising awareness about coronavirus, how the coronavirus pandemic affects kidney patients and transplant patients, and talking to people about the COVID vaccines and the importance for kidney and transplant patients to get the COVID vaccine. I've also, as I mentioned before, done a lot of work talking to people about organ donation, sharing my story, trying to raise awareness about why people should be organ donors, or why they should, or even consider being living organ donors.
Okay. I've noticed another theme in your work is your commitment to minority patients based on your own personal kidney patient experience. Can you talk to us a little bit about that, please?
Definitely. So we know that people of color, Black people, Hispanic, Asian American, Native American, we face increased burdens of kidney disease. This is for a variety of different reasons, but some of it can be traced to health disparities that are seen within the medical field in terms of access to care, access to different kinds of resources that they may need to be able to we may need to be able to improve our kidney health. And so being able to talk to different communities and let them know why kidney disease is important, and why they should be aware and get screened if they might be at risk for different diseases like high blood pressure or diabetes that would put them at increased risk for developing kidney disease. I think it's extremely important to be able to reach different communities and to make sure that they understand how this affects them, and what they can do now to be able to prevent things from getting worse.
Okay, let's talk a little bit about some of your awards, because you're an awarded guy. I was kind of surprised by all of them. So just a couple that I wanted to talk to you about. The 2019 American Kidney Fund Hero of Hope Award. Can you tell us a little bit about that?
So that was, again, after I got involved with the American Kidney Fund as an ambassador, being able to go and speak with our legislators. One of my colleagues was kind enough to nominate me for that award, and I think I was really honored by the opportunity to receive that. One of the great things is that my dad was able to be there at the award ceremony to present me with the award, and he was able to give a little bit of speech and talk a little bit about my kidney disease from his perspective. And yeah, it was. I've really enjoyed working with the American Kidney Fund through their educational efforts and the legislative advocacy that they've allowed me to take part in.
On the research side, I noticed that you won an award from the American Society of Nephrology, the Jared J. Grantham Research Scholar Award. Can you talk to us a little bit about that?
Sure. So that was an award that basically helps to fund my salary while I'm trying to do this kidney disease research that I mentioned before, in terms of trying to find better ways to understand and study kidney disease by studying kidney tissue in a dish. And again, I'm very fortunate that I'm at a great institution like Stanford, which is a leader in biomedical research, and so I have access to really world-leading experts in trying to develop different kinds of new ways of studying disease. And so I've been able to take some of the experience of other people in other fields and try to find ways to apply that to kidney disease. And so again, was very fortunate that the ASN, the American Society of Nephrology, saw value in that and is supporting me in doing this research.
Okay, let's talk about the advice that you're giving to parents and caretakers of pediatric kidney patients concerning COVID-19, precautions including vaccination, your position on the current vaccine trials that are going on with pediatric kidney patients. Can you speak to that a little bit?
Right. So as of now, the vaccines are not yet approved for kids younger than 16 years old. So the most important thing that people can do right now is make sure that all the household members of kids with kidney disease who are eligible to get vaccinated. That's because when any one person gets vaccinated, it helps protect themselves, but it protects all the other people that they come in contact with as well, because it reduces the risk of them carrying the virus and passing it on to the people that are at risk. And so since right now, kids are not able to get vaccinated directly themselves, making sure that their parents and their older siblings and other people that they come in contact are vaccinated is extremely important. There are trials going on in expanding the use of the vaccines, particularly the mRNA, Pfizer and Moderna vaccines to children. It's expected that within probably the next couple of days or weeks, it'll be expanded to teenagers, 12 to 16, I believe, and that there are also ongoing studies in kids younger than that as well. Of course, as a pediatrician, I love vaccines. I think that vaccines are fantastic. They work, they save lives, and it's extremely important that kids get vaccinated. There are so many vaccine preventable diseases that I have never seen in my career as a pediatrician, because there are vaccines for them. They've essentially been removed from circulating, and now kids don't have to die because of these diseases. And the same is going to be true, I think, for the COVID vaccines once those are made available to kids. There has been a lot of attention, and there's still a lot of questions that remain about the use of the COVID vaccines in all patients with kidney disease and with transplants in particular. Speaking about adults, I know Valen was on your podcast, on your show last week, right. And she spoke a lot about the Hopkins study, looking at the antibody responses to the COVID vaccines. That group out of Hopkins actually just published a new paper earlier this week with updated information that showed about half of patients with some sort of transplant who got one of the mRNA vaccines had a response and developed antibodies to the vaccine, which I think underscores the importance that people get the vaccine. That was a big increase over what was seen in after only one dose. So after only one dose, only about 15% of people studied developed antibodies. But after the second dose, that increased to close to 60%, I think. So the importance of not just getting one, but getting both of them. It is true that the response in transplant patients is less than ideal. It's less than what's seen in the general population, where the response rate is close to 100%. But I think any kind of protection, any chance at protection, is better than no chance at all, because this is a potentially serious infection, and so being able to do something, whatever you can, to try to prevent that is important. But another takeaway from these studies is that even after you're vaccinated, you can't assume that you are fully protected. Even if you get antibody tested, you can't assume that you're fully protected as a transplant recipient, like one might be able to in the general population with a normal immune system. That's because, again, there's a large portion of the population who get the vaccine that have had transplants that didn't develop antibodies. I, for one, am one of those people, one of that 40%. I had my 2 vaccines. I was fortunate as a healthcare worker. I got the vaccine very early. I had my first dose on Christmas Day, but I got tested as a part of that Hopkins study, and I just got back my 3-month post-second dose vaccine test and showed that I did not have antibodies. And so it's important that I continue to do all the other things that I was doing all along to protect myself from getting the COVID virus. So that includes maintaining social distance, avoiding gathering with people indoors, unmasked, and making sure that I'm at least wearing a mask. This is even more important now that the CDC guidelines have started to loosen as more people are getting vaccinated. The new recommendations say that vaccinated people don't have to wear a mask. But even though I am vaccinated, I am going to continue to wear a mask because I know that I may not be protected. by the vaccine. It's not all doom and gloom, though. There is potential hope that even though I don't have antibodies, that there are other parts of my immune system that might be activated by having gotten the vaccine that will prevent me from getting more severe COVID infections, even if it doesn't prevent me from catching the virus. Again, we don't know because not enough transplant patients have gotten the vaccine and been exposed to the virus yet to be able to see those numbers. So again, take-home point, all transplant patients, I think it's imperative that you get the coronavirus vaccine if it's made available, when it's made available to you. But that even if you are vaccinated, that you continue to behave as if you're not vaccinated by wearing a mask and taking precautions, avoiding large crowds.
Doc, I get a sense that people like me that are transplant patients on immunosuppressants, we're going to be looking at a booster shot sometime real soon. Is that also your impression?
That is one of the leading discussions within the area.
Okay, not a question, but a statement. I understand that Dr. Fauci is going to be speaking at Emory College on commencement on May 16th.
That's
your
right.
alma mater.
Yeah.
Congratulations, Doc. Last question. Is there anything that I didn't ask you tonight that you would like to discuss? Do you have any closing statements, any material that for some reason or other I didn't cover that you want our audience to know about?
No, I think you covered a lot of things. I think my main take home is that, there's in kidney disease, in the pandemic, and dealing with coronavirus, there are always going to be ups and downs. And I think having a positive attitude is important, and being able to roll with the punches. I think that's what served me the most well in terms of getting to where I am today. But I think at the same time, acknowledging that these setbacks will happen, whether it's rejection or not responding to the coronavirus vaccine, and being able to give yourself grace to mourn that and to grieve that sometimes, but that not dwelling on that and trying to move forward.
Okay. Doc, I appreciate very much for taking time to come and speak to us tonight. Man, learned so much. What a great talk. Thank you for coming and participating. For my audience, May 28th, Curtis Warfield is going to be with us, the Celeste Award winner from the National Kidney Foundation and my partner in crime in kidney advocacy here in Indiana. On June 4th, Dr. Holly Koncicki, Koncicki, is going to be with us. She's going to talk about palliative care. The last Friday in June, I'm trying to get Kent Bressler and his doctor to come on and talk to us about kidney transplants over the age of 50, elderly patients and kidney transplants. So we got our finger crossed there. I will ask the doc concerning your questions if sometime when he has time, if he'll take a look at them and see if he can address those. Until then, watch this space. I'll talk to you soon. Bye-bye.
CJ Ike, now I gotta roll with ice. Cold, these brothers my guys, know that they fly, know that they ride or die. I keep boys by my side, CJ Ike, now I gotta roll with ice. Ride or die, ride or die, ride or die.